Recording in progress.
Okay, so thumbs up to the sound. So welcome everybody, lovely to have you here. We've got people online, we've got folks here in the room, and my name is Margot Parks. I'm here in my role as one of the co-conveners of the Health Research Seminar Series, and I'm also here in my capacity as the co-lead of the Health Research Institute, and I'm really delighted that today we're actually going to be hearing from our other co-lead. It's a big day for the HRI, and our fabulous research manager, who's also going as a technical assistant to make sure that we are in the right place.
They're seeing this screen online.
Okay. Yeah.
Yeah.
That's it.
Goodness.
Is that, are you seeing it right now, Katie? Online? Same again? I don't think it matters. Oh, no, that's right. That's it. We don't see the notes.
Okay.
Yep. So that's just in time to welcome some other folks into the room and to welcome you all here. So our seminar series has been going for quite some time, and is really something that we hold really highly as part of our process. And I'm just trying now to advance the slides. So the folks that contribute to the seminar series, our approach to our HRI work is always very collaborative. We're working across the School of Health Sciences, the School of Nursing, Social Work, the Northern Medical Program, and the Division of Medical Sciences, Psychology Program, and we get some financial support from Sun Life International. So always important to just acknowledge how many people make these collective efforts possible. And our team and our efforts as a Health Research Institute would not be possible unless we had our research manager, Leana Garraway, who is doing triple duty today as technical assistant and research manager and speaker. But the important thing to know is that if any of you are online and you don't know about the Health Research Institute and would like to know more, you can always reach out through this website or by contacting Leana. And we're always open to suggestions. We're open to suggestions for future seminars. And we're also really happy to be bringing you today what feels like a really important seminar focusing on an important initiative for the HRI, because the HRI is also in combination with a number of different initiatives, including the strategy for patient-oriented research. So our speakers today, I'm going to introduce two of them, but we're really excited to have this opportunity. And for this slide, Leana reminded me that the next seminar presentation, ... is going to be a presenter called Margot Parks. It was going to be another Margot on campus, but it is now going to be Margot Parks, decided, committed to as of today. So I'm really looking forward to being the presenter on December 16th. But I'm also really delighted now to introduce Martha MacLeod and Leana as members of our panel and our team today. This is a bit of a VIP introduction to Professor Martha MacLeod, who has been an extraordinary mentor to so many and also a guide of a lot of things on campus. So I've known Martha in many of her hats, but I know it's only some of them. And those include being the head of School of Nursing for a long period, also helping to champion with a group of others to establish the Health Research Institute, has been the co-lead from its inception, and has carried an enormous amount of institutional knowledge in terms of just building the capacity for the kinds of collaborative, relationship-based work that we need to progress. And that's really embodied by Martha's role currently as a research chair and knowledge mobilization research chair in partnership with Northern Health. And that role is an expression of just how much collaborative work Martha has done. Particularly, I got to know Martha's capacity in that knowledge mobilization role and the partnership role through a lot of work in rural and remote nursing practice across the country. So many people across the country would know Martha MacLeod as a leading researcher in the context of rural and remote nursing practice and building capacity in that sense. And she brings those capacities to her roles, as well as having built capacity elsewhere, such as through the Canadian Institutes for Health Research, knowledge translation and knowledge mobilization strategy that over many iterations Martha's been involved with. So if you're reading about knowledge translation and knowledge exchange in CIHR, you can just realize and be proud that somebody at UNBC, including other colleagues like Kathy Ulrich at Northern Health and others, have really helped to champion that work. And it's because of the nature of that partnered work that we're here today with this kind of exciting panel. So Martha, thank you for all of that and more, and for particularly as I have stepped into the role as co-lead of the Health Research Institute at the moment, I'm appreciating just how knowledgeable a colleague is. So I am also really delighted to introduce Leana briefly. And I got to know Leana when she was a master's student. One of the first master's students I worked with here at UNBC, already doing really interesting work connecting with First Nations and knowledge, to thinking about knowledge mobilization and knowledge translation. And she's been a leader in our Health Research Institute as it's evolved in different roles, including as a really important research associate, and now most recently as our research manager. So it's really also important to just watch and notice just the different hats that people are playing. And I think that will be one of the things we'll learn about today, is just the way in which people need to learn across different contexts. So it's always a pleasure to have the opportunity to celebrate work that's being led from UNBC. And I'm really looking forward to this presentation. So thanks, Martha and Leana. Thank you.
I'm just gonna quickly. Katie, can I ask what it looks like? Mm-hmm. I'm trying to get rid of that.
No, I think it's all right now.
Online, because I'm sharing screen, it's showing not cooperating. No. So, picking.
Ain't technology grand?
Just pick.
Well said, Peter.
That screen instead of the computer screen? No, they won't see it online, unfortunately. I apologize for these technical glitches.
Can we fiddle around in the background while you get started, Leana?
I'm sorry?
Or can we fiddle around with that in the background while you
Sure.
get started? Isn't that one minute? Now go to.
This one is okay. This one want to change for me.
You got it.
That looks right.
Okay. Oh, thank you. Okay. Okay. Hey, Katie, you let me know if.
Yeah.
So you want to now make it easier for you. That's probably the way to do it. Here.
Okay, Katie, does it look fine? Yeah. Okay. Okay. All right. Thanks very much, Margot, for that wonderful introduction. My name is Leana Garraway, and I'm the manager of the Health Research Institute at UNBC, but as well I'm the co-lead of the BC Support Unit Northern Center. And so today, myself and my few colleagues who've worked together for several years now on different patient-oriented research work, we're all going to come together now to present and talk about our experiences, reflections, and perspectives on the work we've done. So I'm starting us off today because I'm going to give a brief overview of what exactly patient-oriented research is, and the BC Support Unit Northern Center, what role we play within patient-oriented research in the North. Oh gosh. What are they seeing online, Katie? Okay. No, I can't advance my slides.
That's very frustrating.
Yeah.
We'll have to go out again. And I think it's just that there's so many windows open. Is that what you need?
Can I click that one and I'll remove it from note form?
Yeah, that's probably that. Are you getting the notes, Katie, now?
Mhm.
So
Think that's going to do it?
I think so.
High presenter view.
What would be helpful is if we could, I don't see why that version is not working.
Mhm.
Is that working
Yeah.
now? Is that right for you? It is. Okay. And you use the arrows.
Okay. All right.
This time.
All right, back on track. Okay, so what exactly is the strategy for patient-oriented research? In 2010, the Canadian Institute for Health Research partnered with different organizations, health authorities, and philanthropic organizations across Canada to fund them and create the strategy for patient-oriented research. And the purpose of strategy for patient-oriented research is to catalyze patient-oriented research in Canada and eventually to lead to a cultural change in how research is done. What exactly is patient-oriented research? Well, there's multiple criteria to a project being actual patient-oriented research. Fundamentally, it's when patients are partners. Basically, they're not just participants in research, that they are active participants in the research itself. They focus on patient-identified priorities. The outcomes are measurable. It's generally a multidisciplinary team. And the aim is to apply the knowledge generated to improve healthcare systems and practice. So there are 12 support units across Canada. The one here in BC is called the BC Support Unit. It's located in Vancouver, and there are 4 regional centers around the province, including ours here, the Northern Center in Prince George, and we provide services to the entire Northern Health Research area. Now, the reason that there are so many different support units is because the context is so important. It's important to be in the actual region to identify the appropriate health issues and to bring the right stakeholders to the table to discuss and work on solutions. Here at the Northern Support Unit, that's our basic mandate, is to bring the right stakeholders together to work on healthcare issues that are of importance to the North. We do that by facilitating connections between researchers, patients, healthcare authorities, and healthcare policymakers. We help with team development. We do provide training in patient-oriented research to researchers as well as to patients to help them become involved in research. We have at the support unit, we have a knowledge synthesis center, which fulfills a very important function in helping to synthesize and mobilize information. We have in the past been able to offer some funding as well for patient-oriented research to students as well as researchers. And we also offer multiple knowledge translation opportunities, including the speaker series. So essentially, what is patient-oriented research? Patient-oriented research is multidisciplinary. It involves patients, not just as participants in research, but as active part of the research process and as active parts of the research team. And the main focus is to identify patient-oriented priorities so that the relevant people are included in the problem solving, and then hopefully the knowledge created will improve healthcare systems and practices. The term patient is actually kind of an umbrella term. Patient can mean somebody who has lived experience of a particular healthcare issue, but it can also be their caregivers, their informal caregivers, their families, anyone with experience with this issue. They can all be involved in the research process. And why do we engage in patient-oriented research? Well, basically the term "nothing about us without us" is the underlying reason. It makes the research relevant. It ensures better uptake of the research if you involve the right stakeholders in the process. There are multiple reasons. And now I'd like to pass over to my colleague who's going to talk more specifically about projects she's been involved in.
Thanks very much. I'm Martha MacLeod, and thank you very much, Margot, for that wonderful introduction. We've got two colleagues here today, and that is Peter Zimmer, and you'll see him, he'll come coming up, and he's a retired Anglican priest, a patient researcher on our teams, and he wanted me to know and let you know he's a patient by virtue of having survived 3 bouts of cancer now. We also have a research trainee on our teams, Steinunn Jonatansdottir, who is from Iceland. She's a nurse. She's a PhD graduate student in health sciences, so many of you may well know her. And she's been involved in our projects. We're going to be talking about 2 projects today, and these are patient-orientated methodological studies. Most patient-oriented research is research on a particular clinical or health services issue that concerns the patients, usually as patients. It's the word is, as you saw with Leana, is being stretched now, and a common word, particularly in the UK literature, is patient in public PPI, patient in public involvement, and so the public aspect is there. One of the things that we've been finding is, particularly in work with Indigenous communities, is it's not the individual patient necessarily, but the community. And so the people who identified it, which started off in clinical trials. We've got to get our clinical trials more relevant for patient outcomes. That's really where it started in CIHR, and it's moved. So because it started there, that's why the word patient, and then it became family members or caregivers, and then it's moved since there. Canada is the only country that really talks about patient-oriented research. And that is because it came through with the Canadian Institutes of Health Research, the funders. So what we've done in BC is, with the development of the sport unit, one of the arms of it was to do methodological research in patient-oriented research. And so I'm in a cluster, we're in a cluster that's doing patient-oriented research in the methodologies used in knowledge translation and implementation science. And so that's what I'm going to be talking about, which is the method, looking at research on methods of knowledge translation, implementation science, but doing it from the angle of patient-oriented research. So we've got two studies we're just going to talk about today. One is a hermeneutic study, and the second one is a self-study. So the first one is a hermeneutic approach to implementation science. And we have identified that there cannot be a hermeneutic approach to implementation science, but there can be a hermeneutic approach to implementing. Hermeneutics is a philosophical approach related to interpretation. And so it's not an approach that's used in implementation at all, but we think it's really an approach that is there in our everyday practice as clinicians largely implementing things. The second one is a self-study of patient-oriented research, knowledge translation, implementation, science methodology. So that's our cluster team. And it was because patients have not been involved in methodological studies, it was to deal with that. So that methodological group, the purpose was to study innovative research methods, identify new methods to ensure diversity of approaches for scaling up, and based particularly on citizen science. So one of our studies, one study in the group is citizen science. So here's the 5 different studies that have been funded. And one is consensus method to integrated KT. The second one is our study. Third one is systems thinking tools. The fourth one is using documentary as a method to reach a particular sandwich generation, and that is the usually with women who take care of both aged parents and young children. And the last one is the citizen science one. So what about our study? You can see here that we've got a diverse team. There's myself and there's researchers. Now, we're going to talk about team. We're going to talk about labels. We're using research users both as a clinician and as the Kathy Ulrich, who is the CEO of Northern Health. We've got, I'm using the word researchers, but though that group are people who are academic researchers, professors at universities. We've got a patient as a patient researcher, who's Peter, and a trainee who's Steinunn. And I'm still struggling with the language, and I think we've got to talk as we go through. You'll see why the language is really important. So our aim was to articulate what it means to take a philosophical hermeneutic approach to implementation science in our context. We've done 2 things. One is a scoping review, which is the intersection of hermeneutics and implementation, and then an interview study. And what we've studied with implementing virtual kidney care. So in our scoping review, we did a major review, found 6 studies that dealt with implementing a program and hermeneutics. And you see what these things addressed: assumptions, human dimensions of implementing, power differentials, creating knowledge during implementing, foundational issues such as cross-country cultural communication, and tensions during the processes of change. And that's what hermeneutics allowed to those things to surface or focus on during implementing. In our interview study of virtual kidney care, what we wanted to find out was how to understand what it means for patients and providers to engage in implementing a clinical service. And we then, because it happened during COVID, it moved into the virtual, all virtually. And we had telephone interviews, 17 patients and 10 clinical and service providers, and we're still analyzing the data. So then what is this methods cluster self-study? So in our self-study, we felt we don't know how to incorporate patients into methodological research, because methodological research focuses on process and other things rather than something of a health condition or the direct, a direct relevance to the patient's concrete everyday lives. The second one, we wanted to examine what it means for teams to engage this group. So here's our 5 teams again. And you can see, just a second, the Alan Best at University of UBC, Linda Lee, translational research person at UBC, myself, Nellie Olkey at UBC, UBC Okanagan, and Sarah Monroe again through UBC. So what did we do to do this self-study? We did 2 rounds of one-to-one interviews with 4 teams. 18 people in total, 45 minutes approximately each interview. And we had, at this time, our languages, 4 researchers, 5 patient partners, 2 trainees, 4 research staff, and 3 leads. That's the research lead. That would be myself and 2 others like me. Then they did the analysis, 2 research associates did the interviews. And then they led structured discussion of their initial analysis with 3 out of the 4 teams. Then they did tentative interpretations of the structured discussions. And then we presented those to 8 patients or public partners from 4 teams in 2 small group sessions, because what we found is that we didn't have enough patient voices as we had this, and we thought we've really got to check this out with the patients directly. So what we found out is undertaking, this is patient-oriented KTIS methods research, means exploring opportunities and processes, not content, but processes. Forming the research team meant that you had to make a very good match. Achieving well-functioning research teams, intentionally less flexible, and being attuned to the external context. Now, what does that mean? Here's some quotes that I'd like to talk about. So you talk about how you research the process. It's uncertain. There's a lot of uncertainty because it's exploratory when you do methodological research. We've been figuring it out as we go. And there needed to be a tremendous amount of flexibility on everybody's part moving forward. And that's very difficult for many people. And it's very difficult, particularly for patients who lose track of the plot. The researchers are involved in it. Patients lose track of the plot particularly. And it's so far away from patient care and so open is really challenging in it. Making a good match. First of all, we talked about there being a good fit with a priority problem that we're working on. And the patients then said it's not just a fit into something that's already going, it's making a match. And in making a match, there's tones of the power differential and needing to attend to that power differential of making the match. And that is that the new researchers and partners, the lead reached out and had a conversation about us of different priorities and did a little bit of matchmaking. And then having a relationship, a prior relationship with researchers allowed patients, and I would argue allows the research team to work better with somebody that you know that you work with. And as a researcher, it's who do you want to work with? You want to work with people who have a similar sense of quality. You want to work with people that you know, although they have very different perspectives, that there's a respectfulness and you can listen and learn from each other. And then you can move forward together. People who are going to fulfill commitments is another thing that I really look for in the research team. So one patient here said, potentially the initial approach with a discussion, you bring that divergence together and there's a better understanding. But to gain that understanding of each other, and the goal needs to be happening at all times. You can't just bring everybody together and then expect it to happen. It's got to happen throughout the course of the study. And then you've got to make sure that you address the differences in understanding as that moves, as you move as a team. And as a lead said, it's a bit of a dance to get it right. What happens externally? Well, COVID came along. And one of the things that the teams discovered is that they need to deal with changes with kindness and understanding and having an empathy and genuine care for everyone. Now, in the research world of research teams, that empathy and understanding is not generally talked about. You do your research, you've got your team, you move on with that. there was a new awareness of issues of equity and racism in context of methodology in the team. And that was Black Lives Matter happened at the same time, as did the Truth and Reconciliation discussions in Canada. And so what we have identified too is you've got to be really mindful about the language, that it's inclusive and it's not intimidating. And one person said, really importantly, we've got to get out of the way to break the cycle of same old patient, have to change and do better for people out there in the community who are not privileged. And that had an impact on some of the knowledge translation kinds of approaches that they were going to be taking. So what do we learn about self-study? We learned about interviews and providing feedback gives people opportunities for new understanding. So the teams came to some new understandings and made some adjustments as this happened. Individual and group reflection allows for greater sensitivity and communication. Most research teams, leaders and research coordinators adjusted approaches. Now, the team leaders were all experienced researchers in dealing with varied teams, and that was really key. I think that helped this to happen. And what I learned particularly, that patients need separate opportunities to have their voices heard and understood, because there's a vulnerability even in an open kind of and welcoming time, and some things that will not get said in a group. And it had to do, and Peter can talk a little more about that perhaps. And what did we learn about methodological research? People bring who they are. One of the things somebody said to me, oh, just get any patient. And I thought, no, they won't be able to cope with understanding what hermeneutics might be. And I might be able to do it, but it might just not be the right kind of thing. And so they bring who they are, whole biographies and worldviews. It's not static throughout a project. The team lead and the coordinators are key to this. So as you're heading here, and we need to respond to issues that are amplified through the focus on methodological research. And you can see those things that need to be done. And then power, inclusion, and language of patient partners need to be rethought. Patient partners can put the partner in a secondary role. You've got a main person and a partner to them, as opposed to joint researchers. And as Peter has reminded me, there are patient researchers and non-patient researchers. So I think that's where we'll go. We'll leave that there. And the next one we have up is Steinunn.
Thank you, Martha.
Thank you.
Good afternoon, everybody. My name is Steinunn, and as Martha mentioned, I am from Iceland. Been in Canada for a few years now. And hopefully on my last year of study for my PhD. Woo, almost done. Anyways, regarding the study, when Leana asked or invited me to speak today, I was very happy to have the opportunity to meet people face to face. It's been 2 years now since I stepped on a stage and talked to people. So thank you for that. I'm not sure you're going to get rid of me. And also, I was very happy for the opportunity to share with you how it is to be a trainee on a project like this. So I've been on the project that Martha was talking about for about 2 years, working with that large team. And it has been a very, very good experience for me. It's valuable in more ways than just getting research experience. It is valuable for me as a person. So it is interesting to think about when in the beginning, when I was asked to join the team, I was very excited to get an opportunity to learn more about applied hermeneutics, because I'm very interested in hermeneutics. That's the research method that I'm using for my PhD research. So I was thinking more about that. And also when I read through the list of people who are in the team or on the team, I recognize some of the professors and researchers that have been publishing articles that I had read before, people that I admired for their work. So I was looking into, I realized that I was going to be a trainee and I didn't know much and I had some anxieties about that when stepping in, but I wasn't really thinking about that I would learn about building relationships and getting to know people on a personal level like we did in this team. It was absolutely fantastic. I don't know if it was outside forces, COVID happening, and all these things that maybe brought us a little bit closer together, or if it was the nature of the research approach that was used. What I mean by that is that it is a patient-oriented research, which implies that there is a collaboration that is you're asked to work in a collaborative way. And there is certain types of, you should just take that off, sorry. It's better like that, right? Yeah.
Yeah.
All right, there is a certain, when you approach these kinds of research, there's an expectancy that everybody who participate are at the same level. At least that was what the leaders for this project were aiming for. So as a trainee, when I step into this with all my anxieties of performance, thinking that, you know, I'm not an expert. I even have difficulty with my language and pronouncement sometimes. So I am stepping in there and I'm feeling a little bit low about myself. And what happened during the process was that it settles the feeling of not being good enough. On my first meeting, I felt that I could actually contribute something because I was well received. I found that no one expected me to know everything, and I had a space to learn. And I also realized that with my contribution, I could actually make the project better. So it was an interesting self-realization that came through this that I wasn't expecting. As Martha mentioned, everyone brings themselves to a research team, not just their knowledge or experience. Both the knowledge and the experience are important for sure. However, we also bring ourselves. And I think that aspect is heightened in this kind of study, at least this particular project. I've been part of many teams before, both in clinical practice as a nurse back in the day in Iceland, and through all my studies, all kinds of study teams and stuff that you work together. And in all teams, relationships and relations are part of how well the team functions. And yes, you pick your partners when you're doing student projects, for example. But for research project like this one, I had not experienced this kind of closeness before, as I did this time around. These kinds of studies are about collaboration and weaving together different perspectives, thoughts, and insights. And remarkably enough, my thoughts and insights were thought to be valuable and a good contribution. And that was very good for me as a person and a novice researcher. So for the leader of these kind, and everybody on the team and the leader of the team, it's about creating atmosphere of safety, trust, and respect so that you can feel that you can be open and honest. So being honest and open might be the start of the same process and the end of the same process. So when you go into a team to work together towards a goal, you need to be honest and you need to be open, but you also need to feel safe to do so. So it's about lowering that judgment, if you like, or feeling that you're inadequate, or making somebody else feel that he is or she is inadequate. So being imperfect is okay. And that was good for me to know. I also learned that a patient researcher can play a key role in keeping the team grounded and asking all the right questions to move things forward. And again, over the last couple of years, our patient partner, who was kind of became my buddy from the first day, he kept us grounded, because in this group of people who are all engaged in all kinds of mythologies, epistemologies, philosophy, hermeneutics, you can take the discussion way out of context. You can get excited about things that are just methodological and not in relations to the end goal. And our patient partner was, I would say, one of the strongest person on the team to bring us back and focus on the things that mattered. And in the beginning, I didn't really know why a patient partner was important for methodological research, but I know more now. So thank you very much. If you would take my spot, please, Peter. Go ahead.
Thanks, Steinunn. Hi. Want to talk a little bit from my perspective of engagement as a patient. It's important, I think, whenever you are involved in any research project, particularly a hermeneutic approach, that the mechanisms and the processes are created that form a team. And I think that's important, because university, from my recollection, tends to be competitive. Anybody ever felt competitive? Well, when you get involved in a research project, it's not competitive. It's necessarily collaborative. And the collaboration has to be established between patients, researchers, and healthcare providers. I think it is absolutely important that the experiential knowledge of patients is valued. Anybody here ever been sick? Okay, most of you. Well, you have all been a patient, and you can all speak about your experience as a patient and how that changed and affected you. And it's absolutely essential in a research project that involves patients that everyone on the team is aware of how their illnesses have affected them. There are a few principles that jump out in pursuing the goal of integrating patient engagement. Inclusiveness. The research project has to be inclusive. It has to include everyone. It's interesting. Martha and I were talking earlier, I guess it was last week actually, about the people on the team. And I mentioned to her then, and I mentioned to Steinunn since then, I felt dumb and inadequate when it came to the rest of the people on the team, except for Steinunn. And I thought, oh man, she knows so much more than I do, and she's willing to accommodate my ignorance. The other person on the team, Ian Graham, hard-nosed quantitative researcher, sort of worlds apart from me. Ian and I got along, I think, quite well, and we meshed and we were able to complement each other in our strengths and uncertainties. Mutual respect is so important. Everyone on the team has to respect others on the team in order that the team can be built. When it works, then there is shared leadership. Martha was the team lead in terms of title and responsibility, but she was able to delegate and share that responsibility, I think, with everyone on the team, so that one point or another, everybody felt that they were, to some extent, driving the bus. And when you get involved in doing research involving patients, it's so important that you make sure that the leadership is shared among everyone. And finally, make sure that the capacity of patients, researchers, and healthcare providers is always continually developed in order to work effectively together. There is room for support for creating safe environments that promote honest interactions, cultural competence, training, and education. Finally, there is multi-way communication and collaboration. When people are able to speak honestly with each other, then mutual respect is fostered and honest conversations can take place. Experiential knowledge. I know what it means to live with cancer. You don't know what it means to live with cancer, but you know what it means to live with something that I have no idea about. And if any of us, well, hermeneutic research is necessarily dialogical, okay? And when we are able to get involved in a dialogue, rather than have me stand up here yammering at you, then I can discover things about you that will surprise, delight, and amaze me. Oops, got to go back. And when we do that, then the end result is that our conversation will be much richer than my talking to myself or you talking to yourself. And that, it seems to me, is the end goal of any kind of research, the increase of knowledge. Now, I gave you a clue as to what Steinunn was going to say, or who's going to say that? Martha.
Thanks, Peter. Our last one is a takeaway message, and we're aiming it at graduate students and novice researchers who are less experienced. And that is the patient-oriented research is valuable and important, but when it's done well. When it's not done well, it uses patients as a token. Oops, I need a patient, better put them in, and then there's no communication and it isn't involvement.
It's stupid.
It's, yeah, you're right. Not all research, health research needs to be patient-oriented research. There are bandwagons that happen over the course, and you can see them as you move on in your career. And so the question then is, does every research have to have a knowledge translation component, for instance? And does every research have to be patient-oriented research? The answer is no. You got to really look at what research needs to be patient-oriented. Now, it takes time, a lot of time, and a lot of effort to do patient-oriented research well. So if you intend to do it as part of your, as part of maybe your thesis or your dissertation, or your research at a beginning stage, you could do that. Don't discourage it, but just know what you're getting into and keep your study small and focused. Because when you start to add the kinds of process things that of getting a team together in order, or advisors to start to, it gets more complicated. And the more complicated it gets, the more focused you want your study to be. So your complication is not in your study, it's in getting to your study. So that's the last piece of advice we have, and we'll be delighted to take questions.
So I have lots of questions. That was fantastic. Thank you for sharing that. It's always, I really enjoy panels when we can get this opportunity for exchange and hearing how you've learned together. But I've got a backlog of questions, but I'm going to hold it open to the floor. Does anybody have questions for any of the panelists? Oh, you've shot them all into submissions.
Is there anybody online too?
Yeah,
I don't know what the chat says.
There is a question in the chat. That's fantastic. No, there isn't. Oh, there isn't, but there will be. Okay. So I'm going to, of the many questions that we have, I'm actually going to pick up on that very last point that you were making, which is such an important one about the more complex the research is, the sort of more focused you have to be, because that is often people feel like, well, if the context is complex, then I can't do the work. So I have to sort of diminish the context. I have to sort of somehow diminish reality, not want to talk to somebody or experience the messiness of things. So I just wonder, that sounds like an area where you've learned lots of lessons, and I wonder if you could just dig into that a little bit, because it's such an important one, because so often people delete things in order to simplify things. And I think you're hitting on a really important idea that you can embrace the messiness of things, but you can still design a focused study. And I don't know, I know how difficult that is. I have to advise students on this all the time. So does anybody have any reflections on that? Steinunn, you're in the thick of it, or Martha or Leana or Peter?
Do you want to?
I'll start with it, and the piece that Margot said was really important, is don't cut things out. Rather than have a big idea that you're going to cut things out of and do partially well, focus your attention in one area that's important. When you work with patients and with others, you can't just say, I've designed this, will you come on board? You have to then design with. As soon as you start to design with, then it becomes more complex and the timing takes longer. And as a student, this is your thesis. This is, you need to produce something at the end of it. And that's one of the challenges that we have in patient-oriented research with the issue of power. because there are some, in our discussions, there were some patients that said we need to have equal power, we need to be involved right from the beginning, all the way through every single step of the way. And Peter reminded me that there was an issue of different kinds of power. And one of the aspects that he reminded me, and I'm just exploring more of it, is moral power. And that's the moral power that patients have. And maybe Peter can come and talk a little bit about that. But as you're looking at, when you're designing, you've got to think what you're accountable for. More so, you're the one accountable for getting your thesis done. You're accountable for those. So how can you focus your attention and work in collaboration, real collaboration, to accomplish something while getting, keeping integrity on all aspects. So I don't have an absolute answer to that. And I think it's very topic specific, but it's a complex notion that I think you've got to work through. And if your plan is to do community-based research, if your plan then is patient-oriented research is your research topic, then you've got to make sure that you've got the time, that you've got the focus, and you've got the process for moving through.
Well, I think you've opened up to Peter a really important question about those notions of power. Do you want to come up, Peter, and expand on that at all, or anything we just heard?
No. Whose is
Please,
this?
would you, should I say, come up?
Right.
No, it is easy to recognize, or it's easy to fall into the trap that of feeling that researchers with academic expertise in certain areas clearly have a certain kind of power that a layperson does not. However, lay people who are patients have a certain kind of power. And in discussing with Martha, I used the term moral power. I think that's an unhappy term, but I can't think of a better one. That is, I've got some knowledge, and because of that knowledge, I demand to be heard. It's not simply that I want to be heard, but I have a responsibility, speaking on behalf of all those people who have no voice in this conversation. I've got a responsibility to speak for them. And damn it, I'm going to do that. And I think that's an important thing. The only other thing I wanted to say that I years and years ago, working on a doctorate in philosophy, I discovered this one great truth. Whatever you start researching on is going to grow. It's going to get big. And so make damn sure you start small, because you can always hold a line and it'll grow. But if you start cutting back, as Martha said, you're going to cut something important out. So focus your research.
Great, thank you. Have we got a question online?
We have two questions online, and
Wonderful.
I'm actually going to pull them up. Number one is actually for you, Peter, and it is, what is the time commitment of being a patient on a patient-oriented research project?
when I, the first research project I was on wasn't really a research project as such, but it was setting up protocols for radiation treatment of cancer patients. And my time commitment on that was probably averaged out to about 2 hours a week. And I think on this one, God, I don't know. It just grew. And it grew and shrank. If you are a patient researcher on a project, as I said earlier, you demand certain authority, moral authority, and you have a deep and profound responsibility. You can't slough off. You can't say, well, okay, I've done enough for now. Because you never can do enough. No, you can never do too much. So I don't know if that helps or not. Talking to the camera.
We've got another question from the floor, and then we're going to come back to Julia's question here. So Toru, do you have a question?
Yeah, thank you very much for this wonderful. It's sort of like a combination of whether it's a rhetoric question or a comment, but nonetheless, I'll say. So necessarily, patient oriented requires relationship building. It requires time. Now, for trainees, that is a commodity that doesn't always exist. I can speak probably to and by the way, EXAM taught me one course I didn't do for a while. So I know I know EXAM. Now, how do we balance one, the need for authentic partnerships and the need for time? That's the first part. The second part is there is this push which is necessary to have processes that are genuinely authentic, that are genuinely collaborative. As we are naturally, some are very good at talking, some are not very upcoming. How do you engage and get the best out of them or the best out of each other in a way that demonstrates respect without I say this because although I haven't done patient orientation as much, as a clinician, when I've ever been treating anybody, my approach is always collaborative. But most of the times I feel like I'm pulling teeth because society has been trained to defer to the experts. So similar to quality. And you are trying to say, no, I'm not an expert. You are an expert because you bring something that I don't have. How do you balance that?
So I think we're going to let you stay there. The camera's on you there. If you stay there.
Thank you. They want to sit here?
Yeah, the camera can see you now. Which is nice.
No, that's all right. You sit down.
No, you sit down.
What do I do? Okay, I'm going to answer the last question. I think Steinunn can answer the trainee question and the balance of time. Okay, I'll answer the last question first, and that was the how do you get people to talk? Now, one of the things that was one of the comments when we got the patient groups together, and somebody said that it was maybe, oh, sorry,
okay.
That's what happened when we got patient groups together, and somebody said that they were we had a group with 2 people. One person had English as a second language, and the other person was very hesitant. They talked a lot about not speaking and not having a voice. because in a larger group. And what they said was having smaller groups was very, very helpful. So in a larger advisory team, they didn't say a word. When they had the opportunity with the leader to then have a two-way conversation or a three-way conversation, they were able to then give their points. So that's one of the things that some of the leaders did, is that they had conversations with smaller groups of individuals or groups of patients outside of the team meetings so that they could then get the patient input into it. It takes a lot of experience in group facilitation to be able to make sure everybody speaks, and then sensitivity in that way. And the leaders tried, but there's still improvements that the patients said that we all could make for exactly that purpose. And that was people not feeling as though they knew what they were taught, that they had the confidence to speak, and so that not having the confidence, the English as a second language, and then the time, and not having that power and not having that voice. So those were things. Steinunn, did you want to talk about?
Regarding the trainee aspect of this, it is true that, well, I believe that this type of study, when done well, is an asset to a trainee to enter, because there is this level of collaboration and people are doing their best. They're putting their best foot forward, as you say in English, to make the conversation happen and the dialogue happen, to create the knowledge and the common understanding. So that weaving part that is being co-created through this kind of work is what we're looking for in these studies to begin with. So it's a human relation that we are trying to ignite. So what do we do when we want to connect with another human? So what are our tactics in general? We are friendly, we are kind, we listen, and we listen actively, that we try to hear what people are saying. We might even repeat it. We might voice a different opinion, but we do it in a way that shows respect. So putting your best foot forward here in connecting with others is what happens in the beginning. And for me, it was an interesting experience in a team or a group of academics that I looked up to. I don't think that they were trying to be bigger or better or showing some, prestige. They were just normal people that participate in a project. It was more me that didn't have the confidence to step in there and to have a voice. But their mannerism and the mannerism and tact in communication was the thing that created this this atmosphere.
Mhm.
Does that answer the question at all? Okay, thank you.
So we've got a great question online, and our online colleagues are just doing a really nice conversation huddle on their screen, which I think is great because that's it's what you're talking about. So I'm going to ask the question here from Julia Bickford. She says, fantastic presentation. Can I have a couple of questions? Can you tell us a bit more about how patient partnership impacted your knowledge translation activities? So how the dynamic, and how do you think the research landscape would change if patients were actually decision makers about research funding? Great question.
Yeah.
So Martin, do you want to have a go at that?
Yeah. Okay, if I do the answering of this one?
Yes, I can hold it for you.
Yeah.
The first one about patient partnership impacting the knowledge translation activities on our projects, we are in the process of doing that, and so I cannot give you an answer yet, okay, to that. One of the teams, or a couple of the teams, were actively looking at patient involvement in knowledge translation. And one of the teams identified how undiverse its members were. during a time when they realized that the kind of people they were trying to translate this knowledge to were very diverse. Many were did not have access to electronic means. Many of them were not coming at it from the same kind of assumptive basis as the team was. And these were with several patient partners and our patients on the team. And the patients just said, hey, just a minute here. We need to rethink who's on our team because it was dealing with knowledge translation. And so we needed to do, we needed to look at different formats. We needed to look at different environments in which to do this. So they were studying it, but they realized that who they had involved really needed to change. So Julia, I can only partially answer that at this point.
And she was just saying how much she'd like to hear Peter's perspective on this idea about
Okay.
funding. I don't know how much you know about the funding environment, Peter, but it's a really interesting question.
Okay, I can answer one aspect, but let's Peter.
Go
answer.
ahead.
Let's switch.
No. You answer.
Passing around.
The respectful juggle of research team members.
I think that is certainly a goal to be aimed at. I don't think it is a necessary component for good patient-oriented research, but I think it's something that people need to bear in mind. And actually, the earlier project I was on, I was also part of the funding aspect of that. And I like to think that we were better because of my presence. And I'm not saying that, I'm saying because of the perspective I brought. Martha?
I just wanted to say I've been on the Saskatchewan Health Research Foundation has had patient-oriented grants for the last number of years, and I've chaired several committees. And what they have is they have a separate patient committee and a separate academic committee. Patient committee meets, and then a couple of days later, the academic committee meets. Now, there's been development, and apparently Heart and Stroke Canada, it might be Heart and Stroke, but another organization does that. And there was a lot of debate in there between what should the patients get and what should the academics get. And where the debate came down was this whole piece about when a patient comes, they bring their whole selves. And there were some, there was a series of proposals that were in IT at one point. One of the patients was really concerned that they did not have all of the details of the application because they wanted to look at the IT stuff and not just the section on impact on patient. So it's not an easy kind of solution, but I'll tell you, the patients always brought up important things. The overlap between, and this was experienced researchers in patient-oriented research who had been on these panels before. And the overlap over the years between the patient's perspective and the researcher's perspective got greater and greater. But just as Peter said, his presence on that committee made a difference in terms of what got funded and how the different aspects of the funding application were perceived.
So some wonderful questions online. People are talking about what a change maker this might be. I'm just going to see if there's anybody else. Jonathan's got a question there.
Yeah.
And I'll restate it if we need to, but speak up, Jonathan.
firstly, thank you for presenting today. I really enjoyed listening to your insights and perspectives. And I scribbled down some questions on my sheet. But I guess one that I'm really curious about is how do we actually like connect this knowledge to like healthcare professionals, such as maybe it's specialists or physicians, and how to really transcend this into some kind of policy reform. I know that might be a really complex question to answer, but I'd love to hear if you have anything to say.
One of the things that we do is have, if you noticed on our hermeneutic study, we've got a clinical head and an administrative head on the group. And so they, and it's not been perfect. We've not got it smoothly together, but we're listening to what they need as well in terms of what we put out, and then how that voice can come through. Increasingly, there are patient engagement positions in health authorities, and those individuals are working more and more and more with policy and procedure committees to say, get patients involved in them, working with, as planning happens, patients get involved in the planning. And I think the next step then is to do that integration of research and research findings. And that's one of the things that is really helpful at Northern Health in terms of the knowledge translation position that they have. Marcelo Bravo has it, and he's a co-lead of the Patient-Oriented Research Northern Center with Leana. And so I think that those connections are coming, and would certainly be worth writing about in a couple of years once Leana and Marcelo have worked out how that works in actually moving this patient-oriented research into a practice environment.
Thank you, Martha. I just wanted to add to that really quickly. That was something I completely missed in my presentation. The Northern Center is completely 100% a joint initiative between UNBC and Northern Health. We have staff working at both organizations, and we work together as a team. So.
Thank you.
So we have it. We're coming up to our last 5 minutes or so, and I'm really appreciating the answers and insights we're gaining here. There's a comment in the chat box about how much people have seen the research landscape change when patients are involved in the funding committees, and how much people listened. And there's also a mention of the JDRF as an example of family-led funding body for type 1 diabetes since the 1970s. We've got a bit of chat happening here, which is exciting. And people saying what a great job it is. Well, I think I'd like to just emphasize as we're wrapping up. I'll just grab this. I just want to make some broader connections about the research culture here at UNBC, and how much what you've shared seems to have connected that. And I'd like, if you could, Martha, or anybody, to just see is there a difference between the principles that you're thinking about when you're doing patient-oriented research as compared to community-oriented research? And that's a big question, but what I see is a lot of patterns of similarity around relationships, around willingness to learn, about humility, and all sorts of really important things. But it is a different thing when you're dealing with the experience of individuals like Peter, with his vision of all these other individuals whose perspective he's representing. But Martha, would you, or even Leana, who's done both over your time, would you have any observations or reflections about the similarities and differences? Are there things differences that you think are worth mentioning?
You know, Margaret, that's a really good question, because there are so many similarities between the two of them. The only real standout obvious differences in patient-oriented research, at least in my experience, it's a smaller smaller, you've got a research team and possibly 1, 2, or 3 patients, whereas in community-based research, it's so important to have the support of the community and make sure that you're communicating with regularly the community and the leaders of the community. So I think that would be my major difference, but you're right, there's so many similarities. And it just goes back to the basic tenet of nothing about us without us, basically. Does anybody else have anything they'd like to add?
So any final remarks from Peter or Martha? Any kind of, or Steinunn, any closing remarks as you're wrapping up? It's things that you want these students to take away. You've offered so much already. Martha.
We're all just staring at each other.
Did you have something?
No, if you'd like to do final words.
Okay. Just final words. Over your career, you will bring on new things. I started my career doing community-based research and based in community development. And there are some natural paths that one takes as there are new developments. And coming into patient-oriented research, where I am now in my career, just is a natural fit. So keep that in mind. You start with some of the basics and some of the basic principles, and they will carry with you over time.
Peter, any final thoughts?
Yeah, just a general thought. We've got a new puppy.
I've heard.
And she's 4 months old, I guess. Walking her, everything is new to her. As we walk down the road, she'll stop and look up at a raven. She'll chase a leaf. For me, I never noticed the raven or the leaf. Well, I need to say, to some extent, all of you are new puppies. It's all new and exciting for you. And if I can just give you any wish, it would be never lose that newness. Because it's what makes life worth living.
What a wonderful way to close up a really fabulous session. Thank you all for sharing your wisdoms, your insights. I'm really struck by the fact that the way that you have communicated and your lessons today are all about learning together, and that curiosity, the new puppy, is about learning. So we're really deeply appreciative of you spending this time with us. I'm really glad that the group got to see you as a group, not just as a set of individuals. So there you all are on the screen. They can see you as a crowd. And that's just it's a really inspirational kind of example of what teamwork can do, what collective learning can do, and what happens when you're better together. So thanks so much, and a huge thanks from everybody here. And we've got almost twice as many people online as we do here. So there's a bundle of input. All right.
Awesome. What did we forget?